Hello everyone, and I hope everybody is doing perfectly fine. So today we'll be discussing about megaloblastic anemia. So we have a broad term, that is macrocytic anemia. Here we have megaloblastic and non-megaloblastic anemia. So how we describe macrocytic anemia? So these are basically here RBC, they are larger. MCV will be more than 100 femtoliter. Normal value is around 80 to 100. Then patient's MCH will be increased. However, the hemoglobin content will be normal as described by our MCHC. So macrocytosis, see, it is noted in 2.5 to 4% of 2.5 to 4% of adults who come for routine checkup. And what we see is 60% of cases, even if macrocytosis is present, you have larger RBC, then also it is not accompanied by anemia. But when we see isolated macrocytosis in smear, it should always be investigated because it can point towards an early deficiency. And sometimes what happens, this macrocytosis, it usually precedes the development of anemia in megaloblastic anemia. So machine count से हम values लेते हैं, जैसे CBC जो हम complete blood count करते हैं, we get value MCV. If it is more than 100, we see it is macrocytosis. Correct? But sometimes machine can also give false values when जब RBC, suppose in cold agglutinin what happens, the RBCs are clumped together, so they give a false impression of increased MCV. In hyperglycemia, cell swells up. Then in extreme leukocytosis also, the automated cell counter, what it can do is give you false impression of macrocytosis. So then what we have to do is we have to examine the peripheral smear properly. But true macrocytosis means where RBC size actually increases. So that increases in your alcoholism, folate and cobalamin deficiency, drugs, chemotherapy, reticulocytosis due to hemolysis or bleeding, myelodysplasia, liver disease, hypothyroidism. So these are conditions where you get true macrocytosis. So now as I said, macrocytes हमें दो condition में RBC की size जो होती है बड़ी होगी in two conditions, that is two types we can divide it. It can be megaloblastic or non-megaloblastic. Megaloblastic anemia, it is basically defect in the DNA synthesis. There is arrest in the S phase of cell cycle. And what happens, there is unbalanced cell growth and impaired cell division. So erythroblast with distinct abnormal morphological features will be seen. There will be abnormal features noted in erythroblast. What abnormality will be there? There will be nuclear cytoplasmic asynchrony. Nucleus appear immature with fine reticulate chromatin pattern, but cytoplasm जो होगा वो अपने time से mature करता रहेगा. तो cytoplasm क्या होगा? It will be more increased and more mature as compared to nucleus. So nucleus will lag in maturity as compared to your cytoplasm. That is called as nuclear cytoplasmic asynchrony. Morphologically, megaloblasts are seen in megaloblastic anemia. Non-megaloblastic, it is related to increase in membrane lipids and macrocytes. So the shape of macrocytes is different in megaloblasts and non-megaloblastic anemia. In megaloblastic anemia, what happens? There is macroovelocytes होती हैं, oval shape होते हैं macrocytes. Non-megaloblastic anemia में क्या होता है? Macrocytes are round. ठीक है? So this is just a rough diagram I have made. So see what happened. So when you have these three values, your hemoglobin and hematocrit are decreased. MCV is more than 100 femtoliter. Okay, so it is pointing towards your macrocytosis. So what you need to do is you need to see the retic count. Retic count अगर increased है, ठीक है, तो it will point toward your bleeding, hemolysis or response to therapy, iron therapy. Okay, if reticulocyte count is normal or decreased, then you have to examine the smear. And on smear, if you note macroovelocytes, Howell jolly body, and hypersegmentation, if these three are present, okay, macroovelocytes are present in megaloblastic anemia. Round macrocytes are noted in your non-megaloblastic anemia. So if macrovalocytes, Howell Jolly bodies and hypersegmented neutrophils are present, then you have vitamin B12 deficiency. If these three macrovalocytes, Howell Jolly body and hypersegmented neutrophils are not seen, macrocytes are absent, ठीक है, then you have false increase. जो तीन condition हमने पढ़े हैं, hyperglycemia, cold agglutinins हो सकते हैं. So those condition where you get a false impression of increased MCV. Then round macrocytes अगर है, ठीक है, macroovalocytes नहीं है, but macrocytes are round, so that is your normoblastic macrocytic anemia. You get in liver, alcoholism and liver disease, alcoholism and aplastic anemia. So now we'll see few causes of megaloblastic anemia and non-megaloblastic anemia. So coming to megaloblastic anemia में दो जो इसके होते हैं, फोलेट डेफिशिएंसी से हो सकता है या कोबैलामिन डेफिशिएंसी से हो सकता है. फोलेट डेफिशिएंसी कैन occur due to your nutritional deficiency, increased requirement, intestinal malabsorption or drug inhibition. Similarly, cobalamin deficiency can occur because of pernicious anemia, small bowel resection, gastrectomy, intestinal malabsorption. Nutritional deficiency हो सकती है, increased requirement, same as in folate deficiency we see, transcobalamin deficiency and nitrous oxide. Other causes like chemotherapy with metabolic inhibitors, orotic aciduria, congenital dyserythropoietic anemia. So all these are causes of your megaloblastic anemia. Then few causes of normoblastic anemia जिसमें round macrocytes दिखते हैं. Alcoholism, liver disease, in hemolytic anemia, shift reticulocytosis or hemorrhage, hypothyroidism, aplastic anemia, obstructive jaundice, splenectomy, pregnancy. Artifactual हो सकता है like hyperglycemia, cold agglutinin and also leukocytosis where you can get false increase in MCV. See, now megaloblastic anemia proper when we are discussing, as I said, this is basically a nuclear maturation defect. There is ineffective erythropoiesis to a very large degree, and this is why this is occurring because of disrupted DNA synthesis. So giant abnormal appearing erythroid precursor, they start up in bone marrow, and 95% deficiency of either vitamin B12 or folic acid. So cobalamin deficiency, it can occur due to it is basically due to deficiency of intrinsic factor which is required for its absorption, and folate deficiency, it is due to dietary intake, decreased dietary intake. Coming to clinical features, now when we see what I said is there are clinical feature when you see this megaloblastic anemia. This is insidious, gradually develops. Patient will complain of your lethargy, weakness, yellow or waxy pallor, dyspeptic symptoms होंगे, glossitis with beefy red tongue or you can say smooth red tongue, loss of weight and appetite, atrophy of gastric parietal cells which leads to decreased secretion of intrinsic factor and HCl. Episodes of diarrhea can result from epithelial changes in GIT. Okay, and then the epithelial change, also important point is that it can cause decrease in iron absorption also. Patient can have iron deficiency anemia also along with the cobalamin deficiency. Okay, and in that case what happened? MCV cobalamin deficiency में increase होती है, MCV decrease होती है iron deficiency में. So अगर दोनों combine हो रहे हो, iron deficiency और cobalamin deficiency, your MCV will come to a normal range because size का difference will cover up. Then other clinical feature what this vitamin B12 folate deficient people can present with are your neurological disturbance which is seen in cobalamin deficiency. Then patient can have tingling, numbness, weakness of extremities which is denoting your peripheral neuropathy, loss of vibration, position, sensations in lower extremities. Then sometimes what happen, loss of memory, depression and irritability can also be seen in patients. Megaloblastic madness होती है, patient can have severe psychosis due to this cobalamin deficiency. Now coming to our lab diagnosis proper. So when you have to approach lab diagnosis आपने start करनी है, then what we'll start with our peripheral blood, complete blood count with peripheral smear examination. So when you see the RBC picture, it is macrocytic, normochromic, content, hemoglobin content is normal. MCV is more than 100 femtoliter and can reach up to 140 femtoliter. MCH increases due to your large cell volume, but MCHC is normal in megaloblastic anemia. Hemoglobin and RBC are normal to very low. Nuclear maturation defect, all lineages are affected. That's why, because here what we see is there is a nucleus का maturation defect हो रही है, तो सारे lineages RBC, WBC and platelet will be affected. You can have pancytopenia in megaloblastic anemia. Relative retic count is normal. In severe anemia what we see is corrected retic count जो होगा less than 2% हो जाता है. Absolute retic count is low and reticulocyte production index also decreased to that is less than 2. On smear when we examine, एक तो हमने देखा macrocytic normochromic anemia. Then what three important features we'll see in megaloblastic anemia are your oval macrocytes, that is macroovelocytes, Howell-Jolly bodies, and then your hypersegmented neutrophils. So what happens is how you define a hypersegmented neutrophils. क्या होती है? When we say hypersegmentation in favor of megaloblastic anemia, this sentence is very important. 5% or more neutrophils when you count with 5 lobes or 1 neutrophil with 6 or more lobe is hypersegmentation. So this term, how you describe hypersegmented neutrophil, even if you have 1 neutrophil in peripheral smear with 6 or more lobe, that is hypersegmentation. Yeah, 5% or more neutrophil with 5 lobes. It justifies the criteria of your hypersegmented neutrophil. Then anisocytosis is moderate to marked, variation in your size. Polychromatophilia and megaloblastic erythroblast, they also appear in your peripheral blood. So this is your 6-lobed neutrophil. You have 1, 2, 3, 4, 5, 6 lobe. So 1/6 lobe justify it is in favor of megaloblastic anemia. These are your macroovelocytes. Fine. This is your teardrop cells. This is your hypersegmented neutrophil. So these are your, so this you can say as a normal RBC. Idhar jo ho gayi, these are ovelocytes. Fine. So this is your Howell-Jolly body. This is the nuclear remnants you can say. Fine. And see, one important cabo ring भी होता है. Figure of 8 है. RBC के अंदर you see it's a 8-like structure which is seen inside the RBC. What is this? This is the microtubule remnant from mitotic spindle, which is indicating a impaired abnormality in production of RBC. Mitotic spindle, tubule का remnant है ये. Then peripheral smear हो गया. Then we come to bone marrow. Bone marrow in megaloblastic is very characteristic. This is hypercellular marrow. You will see number of cells with marked increase in cellularity with ME ratio is decreased. Why? Because erythroid precursors are increasing. So E बढ़ रहा है, तो obviously the ratio will decrease. Half of the erythroid precursors will show megaloblastic changes. How you describe a megaloblast? These are large nucleated erythroid precursor with nuclear cytoplasmic asynchrony. Nucleus lags behind the maturation as compared to cytoplasm. That is your nuclear cytoplasmic asynchrony with nucleus, how you describe it? Loose open chromatin which will stain poorly. Cytoplasm is well developed. It will continue in normal fashion. So large nucleated erythroid precursor with nuclear cytoplasmic asynchrony, nucleus with loose open chromatin, cytoplasm well developed. So these are your megaloblasts. So these are erythroid precursors. So these are your all megaloblasts. And apart from these megaloblasts, we'll see myeloid series की भी abnormality हो रही है. So you will see giant metamelocytes, bands with loose open chromatin in the nuclei, myelocytes with poor granulation. Normally myeloid cells में क्या होती है? Granular होती है. वो उसमें poor granulation हो रही है. Because see all nuclear, so that is nuclear defect. So all lineages are affected. So all lineages are affected. So every cell will have some kind of abnormality. Ineffective erythropoiesis हो रही है. माइलॉइड सीरीज में जो WBC वाली रेंज है उसमें immature precursors आ रहे हैं with giant metamelocytes and bands and myelocytes with poor granulation. Then see when seeing the platelet series, megakaryocytes can be decreased, normal or increased, but they have abnormal maturation. So we are done with CBC, peripheral smear and bone marrow. Now other parameters which will help you. So once you have made this thing, then we need to confirm with this. We need to measure the level of serum cobalamin, we need to measure the levels of serum folate and other parameters. So normal range is like if serum cobalamin levels are more than 400 picogram per ml, that is normal. If it is less than 150 picogram per ml, there is deficiency. 150 to 400 होगा, that is borderline. Serum folate more than 4 nanogram per ml will rule out folate deficiency. So it should be more than 4. Homocysteine is increased and methyl malonic acid is normal. See, two parameters हम देखते हैं, methyl malonic acid और homocysteine. So if homocysteine is increased and MMA is normal, so that indicates your folate deficiency. Both are elevated in cobalamin deficiency and in combined folate and vitamin B12 deficiency. In folic acid deficiency, another parameter is there, FIGLU, formaminoglutamate acid. So that what happens, it is increased in urinary, that it is increased in urine, that its excretion is increased in urine, fine. That is what, because it's an immediate intermediate product है वो after administration of histidine. So there is a block in histidine to glutamic acid, ठीक है. So वो बीच का product form हो जाता है, that is your FIGLU. So that increases in folic acid deficiency. So this table I have made to summarize the laboratory parameters in megaloblastic and non-megaloblastic anemia. Both are causes of your macrocytic anemia. Causes I have described earlier. So lab value, when you see RBC, hemoglobin and hematocrit, though these three will be decreased in both megaloblastic, non-megaloblastic macrocytosis. WBC and platelet will decrease in megaloblastic macrocytosis because here nuclear defect is there. It is normal in your non-megaloblastic. MCV is increased in megaloblastic to much extent as compared to your non-megaloblastic. Coming to RBC, morphology तो तीन कैरेक्टरिस्टिक है, macroovalocytes, Hubble jolly body, polychromasia or hypersegmentation. So these are present in your megaloblastic macrocytosis. Hypersegmentation is absent in your non-megaloblastic macrocytosis. Along with that, there is polychromasia, target cells, stomatocytes and cystiocytes. Another few other lab parameters जो हमने पढ़े हैं अभी. Serum cobalamin will be decreased in cobalamin deficiency. Serum folate will be decreased in folate deficiency. In non-megaloblastic macrocytosis, these cobalamin and folate will be normal, except in alcohol where folate are decreased. Then coming to FIGLU, as I said, it is increased in folate deficiency. Methyl malonic acid increased in vitamin B12 deficiency. Homocysteine is increased in both, and these three are normal in your non-megaloblastic macrocytosis. Coming to serum bilirubin and LDH, lactate dehydrogenase, both are increased in your megaloblastic macrocytosis, and these are normal to mildly increased in your non-megaloblastic macrocytosis. So this is how you approach to megaloblastic anemia. You should know the basic pathology, different causes of megaloblastic, non-megaloblastic macrocytosis, how we approach, clinical features, what are the different clinical features of megaloblastic anemia. Then when we come to lab diagnosis, we start with complete blood count, we do the peripheral smear, we examine the bone marrow in detail, then we go for other parameters, biochemical parameters like serum B12, vitamin B12, folic acid, FIGLU, methyl malonic acid, homocysteine. So we compare these values, and last I had summarized both megaloblastic and non-megaloblastic anemia, the different parameters, how you differentiate both. So I hope it is clear. Thank you so much for your patient hearing. So kindly like, subscribe and share my YouTube channel. Thank you so much.